This is the OverReaction podcast.
Tressa, how are you?
I'm fine. How are you, Jeremy?
I'm doing well. How have you been? How was your summer?
My summer was fantastic. Thank you for asking. Last summer, I waited way too long to take a break, and so I was more intentional, and it was great. I'm back for the fall. I'm here.
That's awesome. So, did you travel much, or did you just kind of stay homebody and kind of do a staycation?
Yeah, a little bit of both. I had the opportunity to travel for work. So I was in Amsterdam at the HLTH conference. And while I was there, I made a bit of a detour to Greece. So that was a lot of fun. I did some time at the beach. And then I just had a couple staycation days to catch up. How about you?
I just stuck around. When you live in the mountains, you just run up and head to a lake or head up the trails or whatever. So we just kind of stayed around.
Neat.
Yeah. So how did you get into healthcare initially? Healthcare IT?
Well, why don't we start with how did I get into healthcare? And then we can talk about, this is like the accidental tourist, I think.
Nice.
But so my undergraduate was in biology, and I had to pick between big sciences like botany, human physiology, or molecular sciences like molecular or biophysiology, the cellular physiology. And so I indexed on the molecular side, things that happen within a cell as opposed to whole organisms. And after I graduated from college, I did research at Johns Hopkins, protein chemistry research in a basic science lab. And I loved the people. I found the work intellectually stimulating, but socially isolating. And, ultimately I hated it. So I ended up volunteering to do other things, one of which was to implement a network, an Apple network in our biochemistry lab. And the sciences are the sciences. They're human sciences, they're computer sciences. At the time, I thought, well, maybe my problem was the molecular, human physiology thing, and I'll go back to medical school. But while I was there and that project on automating the lab, I got pretty excited about computer science. And so I just took all that like scientific method in my brain and repurposed it into the information sciences. And, working at Hopkins, they, back in the day, had some nice tuition reimbursement. They helped me get my master's degree on managing technical professionals. But then I didn't want to find myself with another degree that I wasn't going to be happy using, Jeremy. So I interviewed at EDS, Electronic Data Systems, and I became a systems engineer for them. And I was in a completely different industry, but at the time, they had customers and products in the hospital and healthcare industry. And I guess someone was looking at their employee database and they landed upon this Tressa person who did have exposure to the healthcare environment. And they kind of swooped down and picked me up out of the computer science area. And they asked me if I wanted some education on contract negotiation, managing accounts, customer service. And I ended up running a bunch of, initially one and then a handful of hospital-based installs that they did. They actually used to have a clinical system back in the day.
Oh, yeah. That's right. I totally forgot about that.
It was a long time ago, and it didn't get a lot of uptake. It was in the early days, but it's interesting because I have certainly stumbled across other people who started their careers at EDS as well.
And then from EDS, where did you go? So when did you actually get into working for the health systems and hospitals?
Yeah, well, when I was at EDS, my very first healthcare account was Jersey Shore Medical Center in Neptune, New Jersey. And they were a big SMS, shared medical systems install. And here's a small world story for you. I was put up there to manage the account, and they put me in an empty patient room on the AIDS ward because that's where they put IT people. And they partnered me with this very enthusiastic nurse manager to work with me on continuing to expand our clinical system footprint. And that nurse, who'd not ever done any IT work before, her name was Mary Alice Anacarico. And Mary Alice retired, I believe, a year or two ago as the CIO of Henry Ford.
Oh.
So, you tell these little stories about connection points. One of the first mentors that I had when I was at EDS, Jeremy, she was a nurse informaticist installing the clinical system at was then called North Arundel Hospital. She taught me so much. She recently retired as the CIO of Johns Hopkins, and her name's Stephanie Reel. So, there are some really long tenured, well experienced people that I have had kind of the benefit of being imprinted on from their greatness, if you will.
Absolutely. And I'm sure people could say that about you.
I would hope so. I'm not sure everyone would.
I don't think any of us can say that. I mean, you can't make an omelet without breaking a few eggs. You can't be productive without I'm sure knowing a few people here then. So you went from EDS, if I remember right, to MedStar. Is that correct?
Well, this was before MedStar.
Okay. Gotcha.
Yeah, so I hopped around at a lot of hospitals who now are part of a variety of different systems.
Sure.
I had an IT role at Harbor Hospital that's part of MedStar. I was in a clinical director role at Georgetown University. I had some university responsibilities and some medical center responsibilities, but their hospital portion is now part of MedStar. I worked for a big long-term care company for a number of years. Greater Baltimore Medical Center, an independent, acute care hospital system with really deep and broad hospice work here in Baltimore, and then LifeBridge.
So you've worked with obviously shared medical that Siemens bought. What other big enterprise kind of EHR, patient accounting systems have you had to manage, install, take care of?
You want me to talk about patient accounting specifically?
We can do EHR. That's the one that seems to be
all right. Well,
the hot button one, so to speak.
Yeah. So McKesson, Meditech, Shared Medical, SMS, RCO, and Vision, their signature system, which is faculty practice, Oracle Health Patient Accounting, Epic. Epic probably the least, as part of a system selection, but not with a lot of tenure over implementation.
Got you.
And then, of course, a lot of the Part B systems. So what do I mean by that? IDX, Athena Health, I mentioned Signature, eClinicalWorks, again, Epic in the prophy space, because, at the end of the day, they started really in the practices.
Yeah.
Trying to think of some others. There are a handful of others there that are more in the practice space. And then, golly, a variety in hospice, in DME, in urgent care, oncology. So pretty expansive in the EHR space. Although the market's getting smaller and smaller.
It seems to be. And I wonder how dynamic it feels like it's going to get really dynamic, because I don't know, and I would love your take, and you have more insights than me for sure. I don't know if what you would consider an EHR today is actually going to be around in 5 to 7 years. Like, it feels like with the AI and the agents and scribes and data analytics and all that kind of thing, that, EHRs that were kind of built for patient billing really are going to get kind of, I wouldn't say blown up. I don't really know. It does seem to be like Oracle Cerner is heading one direction, and Epic is kind of just still going the traditional meaningful use route. But do you think I'm off base on that, or?
So I think there are two different questions there.
Okay.
Question one would be, do I have an opinion or an understanding of the different vendor strategies? And no, I mean, I don't have a bird's eye view, but similar to you, Jeremy, they all want to continue to grow and develop market share. My observation is Epic does a heck of a job, has a really broad customer base, and the only way they're going to continue to grow and increase revenue is to displace other people. And, they've done a handy job on that with the people who are going to move or who have revenue to switch from whatever they were on to Epic. Mm-hmm. So, at their recent user conference, they're going to put out an ERP. So maybe in the next healthcare environment, your single system is a combined EHR and ERP system. We'll see. I think there's some argument to that and how effective that'll help you manage, especially surgical expense, which is, besides labor, one of the biggest expenses in a healthcare system. So they're pushing into other markets, and they're displacing business partners. It used to be that before this year, Epic wasn't offering ambient AI, and there are a lot of startups that really had promising futures, and now we'll see if they're even around, because Epic's now decided, like Oracle, to do it themselves. Oracle's doing everything themselves on the AI front, and it's been fascinating.
That's what I've heard. I've been reading a lot of and not in the articles or the posts, etc. I've been reading aren't from like just journalists. These are people that are actually have kind of seen, or I got to look under the covers at Oracle. So I think that's got a lot more credibility on what's being reported right now about what you just mentioned.
Yeah, I was at their health conference last week, and we saw not PowerPoint, but real a production ambulatory EMR. And
is that the one that's just they completely rebuilt?
They've completely rebuilt. They're in the process of completely rebuilding both. But what was really fascinating is their data, their transition strategy is to rebuild the executable and the user interface, but to do a dual write of your data, so that all they need to do is light up the new EHR against your existing data. So no conversions.
Really?
Yeah. So they've got a real speed to value roadmap that is pretty intriguing. Would
people need to go from the Cerner RHO to OCI first?
No.
Really?
Wow. What they're going to do is, and again, I'm creating a Tressa-ism. This could be factually incorrect, but the outcome, I believe, is directionally right. And that is that they're going to create a dual write, so that your data, both behind the scenes and then in real time, is going to get written to both OCI and the current data store. So you're not going to be migrating data. OCI is going to have your data, and they literally are going to merely be accessing your data through new executables.
So because that dual write, so you can have a test environment and make sure all the bugs are worked out, and then just turn off the other. Like,
you got it.
We're good. Okay. That's pretty slick.
Yeah, there's no massive migration. They do all the work. Anyway, it'll be interesting to see how they execute on it. But so what does that tell us? That tells us that at its core, this is a tech company and it's got deep pockets on accelerated skill and development. I mean, their pace of new product, we went from an organization that for 4 years was barely offering anything to one in which not only is our head spinning about product, and look, there are a lot of skeptics who've been sitting around waiting for something for years, and so it's like, yeah, right, I'll believe it when I see it. But they're executing on it. They have real live customers. I met customers who just signed with them. And you made a point about it looking very different. I think it's going to look incredibly different. I think that between mobility and voice, that our mobile care providers in the clinic and at the bedside over time will have no idea what the actual EHR data structure looks like, because they won't have to. Their whole workflow is going to be mobile and voice enabled. They're going to be taking pictures, using their voice, and they are not going to go back and touch a screen.
Wow.
They aren't. I mean, over time, I'm not going to need a PC refresh program. Sorry, all you hardware folks. We're going to have to find another place to go. But it's pretty fascinating, because then you start thinking, what am I spending money on? And even more so, and now I'm going to really kind of go off the rails here, so you can yank me back and slap me around.
No, I love it.
Keep me in my lane. But, I was like, what is the fascination about AI? Why is everybody spending so much money on it, right? What's the hype?
Yeah.
And where's the real promise? And then I'm a bit of a podcast junkie. I listened to an episode of I think it's called All In by Chris Hayes. And
yeah.
So the group was talking about AI. Is it hype? How long is it going to last? Blah, 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 blah. And they said that their discussion turned to something where it was like a light bulb went off. And it does relate back to this EHR thing. So think about it this way. There was a time where if you wanted to use the internet, you had to go to work to do it. If you wanted to use a piece of computing equipment, you went to work to do it. If you needed a mobile phone because you were in sales, work gave it to you. But now, Jeremy, we as individuals have carved out a piece of our monthly income for every one of those things in our personal lives. They started in the workplace. Now they're personal choice. And in that podcast, what they made clear is that this is a $1 trillion a year addressable market, i.e., when we get to a place where Jeremy Bickman says, okay, I know what my paycheck says every month, and I'm willing to take $20 out of that paycheck so I can spend more time being productive with a tool I just paid for to buy me another hour on that mountain bike each week. That's the end game.
Now you're speaking my language.
So the end game is the consumer spend on AI to make us each more productive. And when I saw it in that light, so today we're giving mobile and ambient to doctors. We're starting to explore it with nurses, et cetera, et cetera. In 10 years, maybe they're bringing their own way of doing business, and the EHR is just storing the data.
Yeah, it's kind of like an operating system, right? I mean, it's kind of what's interesting to see Oracle heading down the path that is so quickly, because I think if I had to guess from what you're saying and what I'm hearing and other people I'm talking to, is they see that day clearly in the next how many other years it is. And so it's, how do you get ready for when doctors, nurses, coders, patients, or whatever, they just have their own agent they're interacting with, and whatever you have, better work with it. It just better work with it. And then it comes down to, how do the big legacy enterprise EHR vendors charge what they've been charging all this long for? They better have something amazing for that, because I think it'll be kind of hard for CFOs, et cetera, to go, we're spending how many hundreds of millions of dollars a year on what exactly? And we're having to have all these agents and other sorts of things. We need to get control of this back a little. That's how it feels to me a little bit.
Well, listen, we are the only industry, healthcare is the only industry where investment in technology has not translated into increased productivity. Shame on us. Shame on us. And true. A big part of it is it took government intervention to get adoption. And what we adopted were really poor tools in the hands of really smart people. And absent that Keynesian supply and demand competition, things have been slow to get better. And listen, at the end of the day, some of it's really just going to come down to the technology. The technology is moving at such a fast speed. People do need to make sure, even though many, many more clinicians are at the CIO helm, you better make sure you understand the technology of what you have, because at some point, like other decisions we make, they come to a stopping point, or they end up becoming the limitation for you taking the next step.
Totally. I mean, so I think obviously the ambient AI, the voice scribe, or however you want to, I've seen too many names for it. That just makes a lot of sense. It'll free up physicians and nurses a lot of time. They could spend more time looking at the patient rather than on the screen. It should cut hopefully an hour or so a day of documentation. So that seems to be a no-brainer. Are there other areas that you see also kind of becoming no-brainers in terms of utilizing AI over the next, year or two?
Well, so let me just kind of share what I saw last week, which is, a demonstration where the user, as a clinician, through their earbud, said to the EHR, I'm not understanding why this patient who's hypertensive isn't on any kind of hypertensive medication. And very similar to what you might put in another kind of next generation chatbot, the agent walked the entire EHR as an LLM and then brought back to the clinician the elements in the EHR that suggested why that patient in their history hadn't been put on a hypertensive. They're not making interpretations, but it's surfacing everything the exact same way Google does.
So it really is like a digital assistant, right? So it's not doctors saying AI isn't, there's a guy, I think it's Vinay Khosla or whatever. He's at Khosla Ventures. He's the one that keeps putting out the big VC. They made a ton of money. I don't know if they totally, sometimes the stuff that they say about healthcare, it's like maybe you don't understand healthcare like you think you do. He's talked a lot about AI is going to replace doctors in the next 5 years, and I put a post out just saying, tell me you don't know anything about healthcare without telling me you don't know anything about healthcare. So,
I guess let me offer something else that maybe is more practical, and I hope I hope more positive, because for those of us who've committed to this industry, we've got a real sense of purpose. There are a lot of people who need us out there. And when I mean us, I mean not me, but the people my team serves. Let's get back to this idea that in healthcare, we've invested in technology, but it's not made us more productive. A big element of that is historically, that's not appropriate grammar. Our highest category of expense in healthcare systems is labor. We are addicted to labor. We are a people, we're in the business of people, we're about people, and so it makes sense. Having said that, we have a people shortage. And so what I would submit, and the journey we've begun at LifeBridge, is a workforce development strategy where technology is partnered with our human resources team to intentionally pursue agentic AI solutions where we are struggling to do the job we could do, and ideally at a lower price point than just throwing people at it. Because what you're hearing out there, even if we could, there's not enough people to throw at it.
I agree. That's the whole thing. And some of the more, I think, thoughtful kind of futurist philosophers, tech philosophers, et cetera, not necessarily just in healthcare and other places. It's about these digital assistants, these, agentic AI that's helping people be a lot more productive in their roles, right? So like that example you talked about, they got the earbud. The AI is acting like their assistant. Let me go find that out. Like,
that's right.
I don't want you, you're not going to diagnose this patient, or don't get in my ear and tell me something. Just as I'm going through, I want to be able to say, what did I miss?
That's
have
right.
it go through quickly, and let's pull the history and let's find everything out. Like, hey, we pulled in, they got an Apple Watch, so it's pulled all that in. We got all this longitudinal patient data that's already in our EHR, and here's some new information from they visited this clinic or they went to the ER. Here's why they're not on the hypertension drug. And then it's, great.
That's right.
So it's not doing the thinking for me. It's that no one can process all this information quickly. So I'm the physician, or I'm the nurse, or I'm the person at the front desk, whatever it is. I have this assistant that gives me exactly what I need when I need it, or I can ask them to find things, and they're like a super fast, super reliable assistant. Everybody has an assistant, and they're experts in certain areas.
Yeah. No, I mean, look, I think that's right. And in our organization, our clinicians are by far the most excited group of contenders around this.
That's awesome.
There are things that we all wish and know and want to be doing better, but it's just got such a heavy manual load that it never gets done to the level that we'd like. I'll give you an example: incidental findings. So you got a chest x-ray for something, and let's say you've got a cough, you're at the ER, whatever. They do a chest x-ray and things look clear, but there's a dark spot on the top of your spleen that happened. Nah, that wouldn't get in a chest x-ray. Anyway, you get an image for reason A, and it indicates that there might be a problem in 2 or 3 different areas, or even just one. I'm going to tell you that health systems try to be in touch with patients and let them know about these incidental findings. They never get a hold of the person. No one calls them back. We are insufficiently staffed to call everybody on the list, because at the end of the day, it's unconfirmed and you don't want to scare people. I could go on and on. And so you can intelligently understand. But on the other hand, I mean, those are real people, and many of those are real clinical situations that if they're not a problem today, will be a problem in the future. And the majority of people want to know about it. And so there's some really compelling AI tools that hover over these diagnostic images and do a really, they follow a workflow process that does all the notifications around incidental findings without a massive cognitive load on the care team who was trying to bring you in for something that was totally different. So it's very exciting to a lot of our physicians and a lot of our clinicians.
Yeah, imaging seems to be like a natural area where AI is being utilized and to be increasingly utilized. I guess pathology over time as well will have the same kind of aspect in terms of notifying, picking something up, notifying the clinician, hopefully making it super easy for whoever's in from the operational or the patient access side to be able to reach out to the patient in a timely manner without, bypassing the doctor who doesn't know, so you don't want to let the patient know an incidental finding without the doctor.
It's pattern recognition, but the ability of a machine to access its data so much more quickly, it makes sense. And clinicians know that. Clinicians know that what's discovered or what's made available from a clinical trials perspective, and that's somewhere that Oracle's going really hard because they acknowledge there are so many people that don't get the opportunity for a unique treatment merely because that treatment isn't visible to the care provider team that happened to be seeing that patient. And how sad is that? So, it's really just the fact that machines, when walking through structured data, can do it faster and more efficiently than humans. But then we, as humans, need to take the responsibility of what we do with that data. So you're right, people know what normal looks like in a vast array or large language model that has millions of x-rays, so that when you're using an AI tool and it does a comparative of your x-ray to that library, it can offer up to the reading radiologist the probability that it's normal because it's already been comparing it to everything. The same is true with our patients. When an AI camera understands what Jeremy ought to look like safely in that patient bed, and at 2 a.m. when he's moved to something that's getting him awfully close to falling off the side.
Yeah, exactly. Yeah, like what you said earlier, it reminded me of something where the AI is knowledge and the human is the wisdom, right?
I don't think I said that, but I like that.
Well, no, it just triggered something, knowledge and wisdom. I can't remember. Some philosopher made some sort of statement. It's a cliche now, but when you said it has all this information and it can recognize these patterns, and it won't make the decision, but it brings it to the person, the human who's going to make the decision, has the wisdom to take things into context and look at the timing, be able to read the room, so to speak, and be like, hey, maybe I'm not going to bring it up right now. I can tell they can't take it. We'll do a follow-up with this, and AI would just go, I'm just going to tell you it, because it doesn't have emotional IQ, but the humans have that emotional IQ and the wisdom, inherited from, thousands of generations and evolution and all that stuff. I know you got to run. We only got about 3 minutes left. This has been great, by the way. Is there anything we haven't talked about that you think we should talk about when it comes to tech or leadership or AI or strategy or anything like that, or consumerism with patients? Like, who knows?
A lack of competition is not a good thing.
Amen to that, sister.
And that's on many levels.
Yeah.
It's on many levels. But I think it's pretty fair to say that one of the biggest downsides to a lack of competition is a lack of innovation. And, healthcare can't afford that, Jeremy.
I agree. I think it's true from a IT vendor perspective, software vendor perspective. I think it's true even with some of the massive consolidation of health systems. I have this saying, which the larger the health system, the smaller the physician and the more nano the patient. Kind of feels that way sometimes.
Yeah.
And then same thing at the payer space. Like competition really does bring out the best in everybody. It's human nature. And so, yeah, I think you're absolutely right. In healthcare, it's true as well. That was awesome. Tressa, this was fantastic. I really appreciate it. So I'll put your LinkedIn bio in the details of the podcast notes, so to speak.
Sure.
We'll put LifeBridge, there's help in the show notes as well, link to it. And then this was just great. I mean, just the way you think and the experience that you've had and some of the insights that you were able to bring up, I think it's fantastic. So I really appreciate the time.
Well, I'm going to drag you around to make me feel so happy about myself every day, Jeremy. But thank you. That was very flattering.
Absolutely. Well, Tressa, have a great rest of your day, and we'll talk soon. Thank you again.
Yeah. No, thank you for having me, and I hope you get out on that bike soon.
I was earlier this morning. I was up at a pro line trying to figure out these new jumps, and it was a little sketchy. So I already did that. Thank you.